Juventus Odinia, the pain management division of Juventus Healthcare, accord a warm welcome to each one of you. At the outset, we sincerely thank Dr. Shushruth Babulkar and Trauma Society of India for giving us an opportunity to be associated with this webinar on complex fractures of upper limb. We also welcome Dr. Vidisha Kulkarni, Dr. Ram Chidambaram, Dr. Dipti Nandan Reddy, Dr. Parag Shah, and Dr. Anirban Chatterjee. We at Juventus Odinia have always been associated with pain management and have been accredited with launching new products for the first time in the country. We have introduced Myotalk, Tendoform, Cetolac P, and in form of patches for the first time in India, Dicloclast and Ketoplast. We are pleased to announce the launch of our buprenorphine patches, which is Bupreplast. I have been entrusted with a very difficult task of introducing Dr. Shushruth Babulkar to each one of you. Dr. Shushruth Babulkar is a founder member of International OTA. He is the president-elect of Trauma Society of India. He is vice president, NAILS, that is National Association of Surgeons, education officer of AO Trauma India, Task Force Lower Limb AO Regional, and he's the chief Center for Joint Reconstruction Surgery, Sushruth Institute of Medical Sciences. I sincerely request Dr. Shushruth Babulkar now to carry on and take this program ahead. Thank you so much, sir.
Thank you very much, Allah. Thanks for the nice introduction from a good friend like you. So formally, let me thank Juventus and Alad Mahajani to pitch in as scientific partner for this meeting, which has been shouldered the responsibility very ably by my colleague and upcoming star in upper limb orthopedic surgery, Dr. Vidisha Kulkarni from Mirrors. Thank you, Vidisha. And to technically put this up, a good friend of mine, Subbu from Science Integra. Thank you, Subbu. I appreciate that. Vidisha and me, we had a lot of churning on faculty who will be national leaders on upper limb orthopedic surgery. So here we have the stars of upper limb orthopedic surgeon from our country, from all corners of the country. Next slide, please. And with this, I introduce Dr. Vidisha Kulkarni, who's going to navigate today's ship. Dr. Vidisha is an associate professor and chief of hand and upper limb surgery at Postgraduate Institute of Swasthayog Pratishthan, Mirrors. She has published many papers on plating, nailing and external fixation and fibular stud grafting. She has a keen interest on newer technology, and as I know, forearm, terrible triad is her favorite. Of course, because of her parent institute, which is the institute which attracts non-unions from all over the country and abroad. She has a huge number of cases in her armamentarium to showcase to all of us, and we to learn from them. And she will, of course, tell us and educate us on non-unions of distal humerus, forearm, and the rest of the upper limb. So with this, thank you, Vidisha, for shouldering my responsibility, and I will ask you to steer this further. Then we have Dr. D.N. Reddy from Hyderabad, another star from the eastern part of our country, who has done his MS from Osmania Medical College and FRCE from Edinburgh, MS in orthopedic engineering from Cardiff, which was the degree which was the huge attraction to do this degree from Cardiff when I was around. And he has FRCS trauma and orthopedics and CCT in trauma and orthopedics from Joint Commission of Higher Surgical Training, UK. He has a keen interest again in shoulder and elbow, and he was in University Hospital of Leicester. In fact, I must tell you, I was working in Leicester when Joe Dias was there as a locum senior reg, came and go. I was there for 2 weeks and that was it. Next slide, please. We have Ram Chidambaram, another young star from Coimbatore and Chennai. He has a huge interest in, again, hand and upper limb, and has been a part of training in South India. He has huge academic achievements to his credit. But to name a few, he is currently the president of Shoulder and Elbow Society of India. He has trained himself from Trivandrum and Kerala, and of course UK, where he has worked for a couple of years, and now he has a special interest in shoulder, upper limb and arthroscopy. Thank you, Ram, for shouldering my responsibility. Next slide, please. And we have another dear friend of mine from Gujarat, which rules the country today, the state. So thanks, Parag. Thanks for joining in. Parag has a special interest again in shoulder. I know he is the last word in shoulder surgery, trauma in particular, in that part of the world. And of course, he has a huge academic experience from fellowship from London, Ontario, Canada, and then of course Coventry and University of North Tees. So thanks, Parag, again for joining in and shouldering the responsibility. And next slide, please. And we have another star from Eastern India, from Kolkata, Dr. Anirban Chatterjee, who is a senior consultant at Medica Super Specialty Hospital. He is a supervisor of DNB and a certified ATLS instructor. And he also continues to have a special interest in hand and upper limb, especially congenital anomalies and pediatric trauma. So thanks, Anirban. Anirban, I believe, is going to join a little later to all of us. But in the meantime, next slide, please. We will continue with whatever Vidisha has planned for us. So over to you, Vidisha. My only two suggestions to all the faculty is, let it be interactive as I suggested. When you will present your case, ask the rest of the panelists, excluding me, and make sure that we, all of us, have a good message end of the case. So all yours, Vidisha. Take over, please.
For this kind introduction and giving me opportunity to learn further. So let us talk first regarding the Zuventus product. So Zuventus has launched this new product, buprenorphine transdermal patch. As orthopedic surgeons, the pain management is mainstay of our treatment, and in India we come across nearly 180 million people who are suffering from pain and in search of good options of painkillers. So we need good options, because currently we are using NSAIDs as majorly, but they are not free from side effects. And as the chronic pain prevalence rate is approaching 20%, we need safer and good options in painkillers. The NSAIDs have many complications like GI upset, ulcers, etc., drug interactions, and they cannot be used for prolonged time, especially in elderly people over 65, because of the risk of renal damage, which is doubled. We have some opioid analgesics, of which morphine, pethidine are not used in India nowadays, but we are using fentanyl, codeine, buprenorphine nowadays. So these are strong agonists for mu receptors, especially the morphine, pethidine group, but they have a lot of side effects. The moderate agonist, codeine, etc., they are used in pain management as well as mainly as a cough syrups. mild agonist, propraxifene, and mild partial agonist of mu receptors is the buprenorphine, today's product, which can be used as a transdermal patch. We are also using pentazocine, nalbuphine, naloxone, mainly as antagonist for morphine. So these mu receptors action, although they give good analgesia, they also give rise to euphoria, constipation, respiratory depression, and some amount of reduced inflammation on peripheral aspect. Stimulation of delta receptors do give analgesia, but they also are convulsive in action. They do cause anxiolysis, but again they reduce GI motility, and they have other side effects. Again, the kappa stimulators, they are good analgesics, but they cause dysphoria, diuresis. They again reduce inflammation. So now search for this product, buprenorphine. It is a partial mu receptor agonist. As previously people have been using morphine, pethidine group drugs, and the patient response was non-satisfactory, as they used to cause tolerance, hyperalgesia, and side effects like respiratory depression, constipation, dependence, and they have got abuse potential. So there was a constant surge and demand for more efficacious and safer option. So then came the drug buprenorphine, which is a semi-synthetic derivative of opioid alkaloid thebaine, which is derived from Poppy papaver somniferum. It is available in 3 forms: injectable form, sublingual form, and transdermal form. The transdermal form is more advantageous as it is non-invasive. It gives slow and continuous release. So the serum levels are constant over prolonged periods. So therefore, abuse potential is reduced. There are fewer side effects with this drug than the sublingual route or parental route, and this transdermal is easy to apply. So this has mu opioid receptor agonist action with high affinity towards this receptor, and it is 20 to 40 times more potent than morphine. Even with low plasma concentrations, it gives effective pain relief. Even with low receptor occupancy, as low as 5 to 10%. So it has slow in onset action. It lasts for long duration. Abstinence syndrome is rare. It is potent analgesic, and it has got ceiling effect on the respiratory depression. So the respiratory depression occurs, but in low quantity. And also same thing with euphoria. It is acting as antagonist at delta and kappa receptors. So the side effects are limited, like constipation, respiratory depression, anxiety, addiction, all these are lower down. So it is a safer drug, as there is ceiling for respiratory depression when used without other CNS depressants. It blocks psychological dependence since it is only partial agonist. Only 1 to 5% reported cases of constipation are there. There is no spasm of sphincter of OD, so this can be safely used in biliary colic as well as in pancreatitis patients. It has no side effects like visual disturbances, psychomotor disturbances, and cognitive function disturbances as seen with morphine, methadone, etc. So in comparison with other opioids, buprenorphine does not seem to be associated with QT wave prolongation, which is seen with methadone. It is useful, can be used in patients with GI disturbances, as it is applied as transdermal patch. It has got long-lasting analgesic effect. The patch is changed only after 7 days, and the adverse effects are low, and the dose is convenient, only weekly administration. This is widely accepted in International Forum on Pain Management. This was introduced in 2005 in Bulgaria and also approved by American Geriatric Society. So buprenorphine is now considered as first-line therapy in chronic pain management. So there was a surveillance of over 13,000 patients, and 70% of patients reported good pain relief. of which nearly 60% were of musculoskeletal origin, 28% were cancer patients, 12% were neuropathic associated pain, and 7% other. And tolerance is not seen as a problem even when continuously given for 21 days. No change in doses is required, and 63% patients reported better sleep with this drug. So it is effective, gives sustained pain relief. There is improvement in daily functioning and quality of life of patients. Patients reported improved sleep, acceptable tolerability profile. It is effective, user friendly, safe, and it has compliance rate as good as 97%. And all the patches were generally well tolerated. So in conclusion, buprenorphine can be used in elderly patients, those with impaired renal function, as no dosage adjustment is required. It is not inferior to oral treatment with prolonged release tramadol or codeine based preparations. So in conclusion, buprenorphine has a unique pharmacology with immediately obvious therapeutic applications as an analgesic of low abuse potential. So I suggest this product to be tried in severely affected patients. Thank you very much. Yeah. So now we are coming to case discussions. This interesting case is shared by Dr. Parag. What was the Parag? Please proceed.
Yeah, so this was a very young gentleman, in his early 30s, had a vehicular accident and had suffered this injury. The year was 2004, so our own experience with various advanced procedures of the shoulder had just started. So and this is what we encountered. This was about 7 days old by the time he made his way to me, and as it's quite clear that it is a 4-part comminuted proximal humerus fracture with a posterior dislocation of the head, which the fracture appears to be quite proximal through almost the anatomical neck kind of area. So this obviously was a dilemma that neither were we very experienced with primary arthroplasties for these fractures, and also the patient was a very young guy of in early 30s. This was his dominant extremity, and he was a painter by profession. So there was all the factors that we needed to do a good job in restoring his shoulder. So
what was the patient, Parag?
Yes.
Age of the patient?
He was about 30, 34, at that time.
So,
early 30s.
Yeah, looking at the CT scan, does the head looks viable? Was it?
Well, that's always the question when you have 4-part fracture dislocations, whether anterior or posterior. That is this head going to remain viable? And I think we have no real methods to really assess preoperatively whether this head is going to remain viable or not over the course of time. So, all the factors that lead to a decision-making dilemma where they're young patient, back fracture, 7 days old, potentially poor vascularity once, even if you repair this. So, again, how would you proceed? And, would like to have the panelists' opinion. Vidisha,
Can I barge in at this point in time, please?
Yes, please.
So what I want to know as a general orthopedic surgeon is, number one, how much am I risking in terms of doubtful vascularity of this? So what should I be telling the relative is my question. Second is, academically speaking, I'm told Hertel's quality of reduction is thrown in the bin now, but what are the pointers which we should be looking at, X-ray wise and CT scan wise, which will tell me okay, I am not going to be really jeopardizing the final outcome in terms of either regaining the vascularity or doing a proper reverse shoulder or total shoulder later on, So what's your take on that?
So yes, as I said, it's a surgical decision-making dilemma. But going to the fact that the patient is hardly in his early 30s, all attempts have to be made to salvage this particular proximal humerus, because you do not want to do a hemi in a or any sort of replacement surgery in somebody so young, because you're obviously staring at a revision surgery in which could be anywhere between the next 5 and 10 years. So all efforts should be made to anatomically reconstruct this fracture. So as we all know that the AVN of the lower limb and the upper limb, they behave slightly differently, because you have a lot of weight bearing issues if somebody has AVN of the hip secondary to a neck femur. But if you talk about the upper limb, although we say that it's a non-weight bearing joint, which is not entirely true, because there are a lot of joint reaction forces in terms of whatever you do. You get out of your chair, your bed, your table, or whatever you do, there is loading of the joint. But again, it's not with the same forces as the lower limb. So yes, you do have to explain the possibility of avascular necrosis. You have to also tell the patient that if it does happen, and if he turns symptomatic, then we may go for an arthroplasty at some point in time. But I think at this stage, the whole idea would be to perform an as anatomic a reduction and fixation as possible, concentrate on early range of motion, and literally keep your fingers crossed, hope for the best. Even intraoperatively, we don't have many ways to look at the vascularity of the head, but you can do some drill holes and see for back bleeding, as you call, whether the small drill holes that you have made in the head, do they have a backflow of blood? If it is, then again, it is a fair indicator. There are no analytics involved here as to whether it's good or how good it is. Even Ralph Hurtel's publications had mentioned this as one of the tests to determine if the head is viable. Although they felt that they were not able to rely too much on it, depending on what happened in the post-operative period. Again, coming back to Hurtel's criteria, I think it's still a fair idea, to have some opinion based on what he suggested, which would mean that if you have a metaphyseal beak of about 9 millimeters or so, that's a good prognostic factor. And I think I do believe that. The reason being, when you have a metaphyseal beak, usually there is some attachment of the capsule. Most of this capsule is actually posterior and postero-inferior capsule. Now, if you look at anatomical studies done in the last decade or decade and a half, our thought of vascularity of the proximal humerus has changed. For the past 50 years, we were all talking about the anterior circumflex humeral vessels and the ascending vessels of that, which is responsible for vascularity. But now we do know that it is actually the posterior circumflex humeral artery, which is number one, more constant, number two, bigger in diameter, and number three, nearly 3/4 of the segment of the head can remain viable if you have this metaphyseal beak with its posterior-inferior capsular attachment and subsequently vascularization from the posterior circumflex humeral artery. So I think these are all the factors that one need to consider before embarking upon a specific kind of surgery. But again, when you're talking about somebody so young, I think irrespective of whether he's vascular or not, my attempt would be to try and fix this. Now, the definition of young, we are obviously living longer, and we are being more and more active. So, it's not just somebody who's 30, 35, but we would extend this to people who are almost between, in their mid 40s to even 50, for that matter. And it's only then later on that we start thinking about arthroplasty options. So this is my take, and this is how I would discuss with the patient.
No, I totally agree with you, Parag. And before I give mic to Ram, I know you are waving your hand. In lower limb these days, in fracture neck of femur with doubtful femoral head vascularity, we are talking of the new MRI, the high resolution MRI. Do you guys consider doing that to decide the vascularity of humeral head, or you will just take that chance? The specificity and sensitivity of this new MRI is supposed to be 99% and more. So I'm asking.
So no, I mean, in my practice, it is certainly not been a routine thing to do to get this high resolution MRIs to judge the vascularity of the humeral head. So currently, my answer to that would be a no. That no, we don't use it to assess preoperatively about the vascularity.
Ram, you wanted to suggest something, and then Vidisha?
Yeah, I think I agree with most of the things Parag has said. But this patient is young and it is a fracture dislocation. The head fragment is dislocated that has to be brought in and put back in the joint. Now, issue about the vascularity, we don't do any MRI to check it. We know that the vascularity is disrupted. We try to preserve the blood supply to the tuberosity fragments, put the head back against the glenoid and fix this so that the healing might happen with creeping substitution. Sometimes, even if the head is dislocated for 2 weeks or over, I have taken it out and put it in the joint and fixed it, still it has healed. Well, the avascular necrosis, the patient has to be warned, it can happen up to 5 years in the shoulder. But if you think like the tuberosities have healed, some creeping substitution blood supply is there, then you might be having a small avascular necrosis to deal with rather than damage the shoulder altogether. So our primary aim is to relocate the joint and reconstruct the tuberosities. Now, my indication to do arthroplasty in this age group is very, very, very small. That means if I can't fix the fracture, that is the only indication. But it is very important to recognize, I have to add one statement, that dislocated head fragment should be located and fixed. Because I have seen occasion where the tuberosities have been fixed to the head fragment and the whole head still remains posteriorly dislocated. That has to be avoided.
Okay, Dr. Nandan, you want to add something?
I agree with all what Parag has said, and I think Hurtle, we cannot completely rubbish his work, and he's done a brilliant job in finding out the vascularity of the head. But one important point I've noticed is that, as I'm seeing patients who've had resorbed heads and people who have had neglected dislocated heads, their function is pretty good even if they don't have the head of the humerus. It is the tuberosity which is more important. So I think our focus on the head should be completely taken off in the shoulder. I think we emphasize too much on this head part of it. I think getting the tuberosities in the right place, making the tuberosity heal onto the shaft is more important to the function of the shoulder, unlike in the hip. Okay, so that is the biggest difference we need to identify, recognize, because every time we put a shoulder fracture, we say, oh, will it go into after the next? That's not a problem at all in the shoulder. Even if you look at Christian Gerber's work, only 50% of the 2% which went into AVN had some symptoms which required surgery. So that is not the point. The point, the focus, the shift should be completely towards the tuberosities.
Agreed. So, Parag, how did you proceed with what approach you chose?
So, the standard approach for me for nearly all fracture dislocations is a deltopectoral approach. So whether it's anterior or posterior, I'm much more comfortable using a deltopectoral approach for these complex fractures. So that is what would be my choice of approach for this.
Any for the reduction of the head?
Yes. So again, it's always tricky to reduce or get this head back. But I think, what we always tend to do is, first of all, with your approach, I always first isolate the long head of the biceps. The long head of the biceps is sort of your navigation tool. So what is medial to that, what is lateral to that. Once you identify that, it leads you to the other anatomical structures. The second is important is obviously the coracoid process, which sort of marks your medial border, the boundary of dissection, because you do not want to go significantly medial to the coracoid process unless you are quite adept at isolating the neurovascular structures on that side. So first of all, identifying long into the biceps. We almost in all such complex cases, even in young people, we do, or at least I do, a biceps tenotomy, and I tenodese it at the end of the operation. So doing a tenotomy actually makes some space for this head to be pushed back. Uh, and at the same time, I would obviously suture the GT, the greater tuberosity, and the lesser tuberosity with sutures of your choice. Usually, they are either a number 5 ethibond kind of sutures, or in more recent times, you could use a fiber wire number 2, or even a fiber tape. If you or your patient affords that, so you tag your tuberosities, and then you always take up at least half of the pec major. I actually extend my medial dissection a little bit if the shoulder is tight, and I not only take down the pec major, but I even release a part of the latissimus dorsi and even the teres from the medial side aspect of the shaft. And what this actually does is it creates a huge amount of medial space, because your shaft can now be taken laterally. And then, with manual dissection and very gentle maneuvers, you deliver the head back into the glenoid. So this maneuver is pretty common, whether it's an anterior dislocation or posterior dislocation. So I would do these steps in almost all fracture dislocations.
Even in posterior also?
Yeah, absolutely.
Okay. Ram, you want to add anything to this?
Approach-wise and technique-wise similar. As he said, the most important step is to get the reduced head fragment. Once you tag the GT and LT with the sutures, open up, you would be just seeing the glenoid. So you have to use some sort of tap, a 3.5 millimeter tap or a awl to screw in the head and gently pull it towards you. The head will come without releasing of the soft tissue attachment it might have already in the neck region. So that is the technique that you do, or you gently push from the back to reduce the head, and temporarily fix the head to the glenoid while you reconstruct the tuberosities. I find is easier to do that way.
And Dr. Nandan, you want to say something?
Yeah, the technique which Ram just described about the tap in the head, I'm always very scared of doing that, because we have very soft bone, in which neglected ones, the bone is already soft, and you make a big hollow of it, you won't have any hold after you have put the head back. So I tend to use, I blunted one of my cob elevator. So a blunt cob elevator, you put on the posterior labrum, the posterior part of the glenoid, and use it as a lever to unhitch the head. So once this is unhitched, then you put a pressure with the thumb at the back, and the head will slowly slide back out into the glenoid. That's one way I do it. And the other way is that if you have a greater tuberosity fracture, you can go from the other side, in the sense the lateral side of the head, and then lever the head out into the glenohumeral joint. So if the greater tuberosity is not broken off the shaft, then it makes it a bit more tricky. But you can always external rotate the shaft to get access to the head.
Suppose if the patient comes 1 month late with this kind of fracture, do you extend your incision posteriorly?
No, so the whole idea is, if you have a delayed presentation, that I have never taken this incision posteriorly. But even if I do a lot of these neglected locked posterior dislocations that come anytime between 1 to 9 months, I would still use a similar approach to what I just described. If need be, again, as I said, and I say that with a little bit of trepidation, that if there is no other alternative, then one may try to take off some deltoid, off the clavicle, and make it a slightly larger approach. But again, the indication of doing that are almost minuscule. So there are reports where you can take a counter incision at the back. You can do 2 incisions. So I think the important thing is to try to reduce this head as atraumatically as possible. Over all these years of my experience, I've been able to do that quite reliably with a single deltopectoral approach.
So we will proceed to your intra pictures.
Right. So again, as I said, this was 2004. So we were just starting to play with locking plates. Even the phelos that we very routinely do today was not introduced. So this was the precursor to that. It was called the LPHP, the locking proximal humeral plate. So that was what was used. And as you can see, sutures which are already tagged, which are tagging all the both the tuberosities, the lesser and the greater. And as you see on the top right corner, the head is facing well opposite the glenoid. I probably did try to get more valgus, but at that time, again, it's a long time ago, I was happy that at least the head was against the glenoid, and I had the shaft, which was slightly medialized, supporting the neck area. The GT was reduced again to maintain your sort of the offset between the top of the head and the top of the GT. I used some cancellous graft along with some graft substitute to fill in some of the defects around the medial aspect of the neck, and I fixed it with this plate, taking care of getting as near the calcar as possible. And this was the final construct. So obviously it's open for criticism as well as comments and suggestions. But yeah, 16 years ago was a long time back.
Now, what is your aim to achieve head shaft angle at least 120 on higher?
I think this is still about between 115 and 120, and anything more than 120 probably is desirable. And again, rather than achieving an absolute anatomic neck shaft angle, which may look very pretty on the X-ray, I would accept a situation where I have preserved most of the soft tissues. I have, well reconstructed greater tuberosity and the lesser tuberosity. I have maintained this sort of head tuberosity offset, and I have a medial contact of the head shaft area. I think these probably would suffice. And obviously, if you can do all this and have a great valgus, I think that's fantastic.
Anyone using tension band wiring apart from ethibond sutures?
Well, basically, even if whether you use wires or whether you use ethibonds, the whole idea is still the same. But we've moved away from wires from a long time. I don't use them anymore, or I've hardly ever used them because that's how we were trained in our fellowships. Because the suture is probably much more versatile and much easier to handle than an SS wire, in my opinion.
Yeah, I
Agree.
Ram, what is your take on the reduction? Would you accept this in 2020?
You have already said everything about the fixation yourself, Parag. as far as I see the humeral head is a good alignment. Tuberosity is well reduced. It is below the summit of the humeral head, and there is contact medially at the neck level for a good orthogonal fixation, and there is also to supplement. Sorry.
Parag, can I just say something?
Yeah.
Please do.
How did the patient do?
We'll see gradually. So this was, these were the X-rays. Very good reduction in both the AP and the axillary plane, and this was, I think, the range of motion at about 9 months.
So this is the point I was trying to make. Actually, the question I asked was because of this. Now, if you look at the GT, forget about the head. Okay.
Yes.
Look at the GT, and the GT. If you look at the top of the GT, it is almost like parallel to the ground. Yeah. So the pull of the rotator cuff is in the right direction.
Right.
And they function well. The more I look at these X-rays, the more I'm understanding that is having more of a bearing than the head itself.
True. I mean, the head is the fulcrum, but the whole power generation is by the tuberosity.
Nandan, but when the head is in the right place.
Yeah, obviously. See, even if the head is slightly off, in fact, I've had cases where the head is not there at all, and they are lifting their hand up nicely. So That is the tricky part. That's why I've started to rethink the whole thing.
So this is again 5-year follow-up of the same patient.
So again, 5 years down the line, he has. If you can, Vidisha, go back to the last slide, the previous slide. Yeah. So even at 5 years, if you just look at the AP, there is just slight waviness of the humeral
On the
head,
head,
but other
yes.
than that,
This is
there
something
is no
which
collapse.
this is something I told initially. It can happen up to 5 years, but
Yes.
most of the time it is very much small and partial.
Yes. Right.
All right.
Yeah, you
Just
can
the
proceed
humeral
to
head
the.
got to that supply.
And this was a 10-year follow-up where he continues to maintain excellent function of his shoulder. He continues to do his job as a painter, and that was his X-ray. So he still is in touch with me, and he's had no problems at 16 years. So I think that's a fairly good outcome for both the
Very good.
patient and myself.
Just a comment
I
on the
think-
lighter vein. I think why is he still in contact with you?
Now, because he sends patients, Dipti.
Great, great.
That's the best contact you need to have,
I know.
I think the key message is any fracture dislocation of shoulder is not equivalent to avascular necrosis. You have to get
Absolutely.
the head back, reduce, reconstruct the tuberosities, use tension band sutures to offload your fixation, support of the rotator cuff and the tuberosities, get the healing. The patient can do very well even in long term. And even though a small avascular necrosis develops, still it can be asymptomatic.
So these are the observations on that. That full substance revascularization has been observed in initial total ischemia, as you said, Ram. That with the head on the side table, you put it back in, and there is still evidence of revascularization. So creeping substitution and revascularization is postulated when the ischemic part of the head comes in contact with bleeding cancellous bone in the presence of a mechanically stable environment.
Yes.
Okay. And it has been reported in Unfall Chirurgy in 1997 that sometimes we believe that dislocations are going to have a higher rate of avascular necrosis, but they found no real difference between 4-part fractures and the fractures with dislocations. So that is good news. And as I mentioned in my observation, that a mechanical stable environment is very, very important. So the image on the left with the philos and the entire head reconstructed well with the head GT relationship maintained has, even though it's a full open reduction, a good 20 centimeter deltopectoral approach. But if you have an environment like that, there is a significantly better chance of revascularization as compared to the X-ray on the opposite side, which has got, just these 2 little K wires trying to do some sort of reduction. So, even if it's done closed, it's not going to really do well vis-a-vis a fracture which is reduced well with its anatomy restored as much as possible. So head perfusion is important, but it's not the only element in decision making. If you have a good quality of bone, go ahead and do a stable osteosynthesis, which warrants anatomical healing, especially of the tuberosities. And in a worst case scenario, if you have good, well-healed tuberosities, you still pave the way for a 2-stage treatment.
Thank you, Parag, for a very nice case.
Good. Excellent.
Case is shared by Dr. Dipti Nandan. Please go ahead.
Yeah, this is a gentleman who is 35-year-old. He operates a Xerox shop actually, and he fell from his bike, and he had this injury. Pretty bad injury to the articular surface of the distal humerus only. One important point was the columns of the humerus are maintained distally. The CT scan, if you can just put on the, yes, that is the images of the CT scan, and you can see that the articular fragments are multiple, especially the capitellar side. You have so many bits that you can't even think of putting everything together. But the good thing about this particular fracture is that the columns are intact, so we don't need a columnar construct. That's what I'm thinking. And then you have osteochondral fragments. These are essentially that, like the humeral head. If any osteochondral fragment, if you go back to basic sciences, if it is loaded and it is in the right mechanical environment, it integrates. And that is the logic in which we reconstruct these sort of fragments. So the most important thing in a fracture like this is the approach to it. So as you all know that the distal humerus, the articular part is anterior, but our approach is posterior. So getting to these fragments is difficult. So looking at the studies from Sheffield and other areas, other units, they have showed that the articular surface can be 70% exposed if you do an osteotomy of the olecranon. So that is what I planned for this patient.
So
And
you went posteriorly for this fracture.
yes,
And what about the anterior coronal shear fragments you did that?
all of them can be done posteriorly because your articular visualization of the whole of the articular surface is pretty good if you do an osteotomy of the olecranon.
So how did you achieve reduction of coronal fragments? From
Yes, so that is the important part here. There were very small slivers of osteochondral fractures. So
Yeah.
what I did was I actually kebabbed these fragments with smooth K wires and held them together. And I put them parallel to the articular surface. So they act as a subchondral support and hold the fragments together. And individual large fragments I fixed onto the intact column with headless screws.
So you put wires from pillars to the articular fragments.
No. The wires go only parallel to the articular surface. So they are not going towards the pillar. So you are reconstructing the osteochondral fragment and then putting this onto the pillars.
I think
You are converting it into a low transcondylar fracture. But how did you achieve fixation with the medial and lateral pillar with the?
I put headless screws going from the articular fragment onto the pillars.
Okay.
Yeah, I think what Dr. Nandan is trying to highlight is that if it is a capitulotrochlear big one single fragment, you could get away with the lateral or pillar approach.
Yes.
But if you have multiple fragments intra-articular, I think it's more advantageous to go back and expose the joint. That's the point you are highlighting.
Yes.
So Ram, would you do the same posterior approach, or you want to differ?
No, that's what I'm saying. If it is a single large condylar fragment or two coronal shear major fragment, as a like capitulum also with the trochlear piece, I would go with a columnar approach, either lateral column, or if it is a trochlear fracture, mainly go with the medial column and then elevate the subperiosteal anteriorly, and you can go. But not for this type of fracture. This type of fracture, I would go posterior with approach only, because as he said, there are multiple pieces. These pieces it will be very difficult to see from the side, so you have to be from the back. By the next challenge, this is technically challenging operation, because we have to fix this fragment, each and everything together, as well as fix to the column. But the regular columnar plate will not hold with its screws. So you might need to change your column, and then you may sometimes move to posterior column plate, not like a parallel plate. Sometimes you might need to use an additional supporting posterior column plates.
So can I add to this, Vidisha? So see, basically these are articular shear fractures, and the simplest one being a fracture of the isolated capitulum, and as Ram and Dipti said, they are quite easily approached through the lateral Coker kind of approach or the columnar approach. The other approach is that one needs to think about is that the whole articular block is anterior, and how do you visualize that? So the one way of doing it is going completely anterior. So you do an anterior approach through the skin crease and then go to your straight direct view of the articular surface. So this is a difficult approach. It is not the usual thing that the orthopod is exposed to, because you have to take care of the median nerve, you have to take care of the brachial artery. There is a Lesater's fibrosis which you need to incise, and then you also need to look and isolate the terminal part of the radial nerve. But it is if you master this approach, it is quite gratifying to fix these from the front. If you can't do that, there is the lateral approach where you can do a lateral epicondylar osteotomy. Okay, so what you essentially do is you osteotomize the lateral epicondyle and then flip your entire extensor mass along with that the osteotomy, and that sort of opens up the elbow from the lateral side, kind by almost subluxing the elbow joint, and then your excess can go almost all the way medial. This again is an unusual approach. It is not something which is commonly done or taught. But again, if you can do that, or sometimes if you have a lateral condylar fracture along with a shear, then it becomes quite easy to reflect that fracture, work through the fracture, fix the shear elements, and then reattach the fractured lateral condyle. However, if it's a pure articular shear fracture with intact condyles and you're not happy or used to an anterior approach, then the workhorse is through the back, and you approach this by doing an olecranon osteotomy, an ulnar nerve isolation, and hyperflexing the elbow. Okay, when you hyperflex the elbow, you should be able to deliver these anteriorly displaced articular segments back to where they belong. And then, as Dipti said, you have to do back to front headless compression screws, or occasionally even from the back of posterior approach, you can do a sort of a front to back as well, depending on the configuration of the fracture. So this is how I would summarize the surgical approaches for such fractures.
Whether you need to dislocate the elbow, distal humerus.
No, you don't actually dislocate, you hyperflex it.
Okay. So you don't need to cut the collaterals, okay?
No.
No need to.
Recently, I did one of these through Joe Pulley approach, where you actually dislocate the whole joint out, but without cutting the collaterals. But what I noticed in that is that I'm finding it very difficult to get to the medial side. The lateral side is very well exposed, but getting to the medial fragment is very difficult. The advantage of having the Joe Pulley one was that you could have the olecranon as your template on which you can build the whole of your articular surface. It was very, very difficult to get to the medial side because the olecranon keeps coming in the way. So you can't put a AP screw from the medial side with the Joe Pulley approach. Whereas in osteotomy, the whole thing is seen. So you can put screws from the bottom, you can lift up the humeral shaft, and you can do AP screws as well.
So Parag, you said osteotomy from which approach, posterior or medial separate?
No. So it's a single approach. So either you do a lateral epicondylar osteotomy, or you do an olecranon osteotomy.
Yeah.
If you are doing an olecranon osteotomy, your approach is posterior, and if you are planning to do an epicondylar osteotomy, then your approach is a lateral approach.
You want to add something? Anirban, you want to add something? Please unmute yourself.
Yeah. Hi. Sorry to join in late, but I think Parag and Deepthi have covered most of it. These are challenging injuries to deal with, and the important thing is to get a good exposure. Without a good exposure, it's difficult and fiddly to try and fix all these fragments, especially if you try and come from the purely by the lateral approach. You just can't get medial enough.
So
can we see the post-ops, Dipti?
Yeah, I think that's what I did. In fact, that stacking of the wires parallel to the articular surface is something I picked up from Graham King. And it seems to work very well because it acts as a nice support. And this gentleman later required the removal of metal. In fact, one of that wires, which is slightly prominent on the medial side, it was walking out. So I had to pull those out, and I had to remove his tension band wiring, implants. But the other fragments seemed to be healed pretty well when I went back in to remove the metalwork. And he regained not full motion, but he regained, I think, around 15 degrees to 130 of flexion. And he was happy with his elbow function.
very nicely done this. This is reasonably good.
This was at 2 months.
Okay.
This is after his removal of metal work, he was slightly better than this.
So how was the post-operative protocol?
All my distal humerus protocol is the same. In spite of it being so communicated, I always mobilize them day one. Because as I told you from basic sciences that if you load an osteochondral fragment, it integrates better. And it also it's molded by the other side of the joint. So it actually helps rather than not helping. The mistake is to keep them in a plaster and then there is scarring between the cartilage and capsule and you don't get the motion later.
Dr. Ram?
Oh, yes.
Yeah, please proceed.
Okay, as a 24-year-old man had involved in road traffic accident 2 months ago, had this injury, which is often missed, as we know. Okay, as you see, can you show the next slide? So that's a problem. You have this alignment of the proximal distal carpal row bones is lost. So what we call is a gilula arc. The three arcs are not collinear. And second is this alignment or spilled teacup sign of the lunate. It has to be aligned with the radius, lunate, and the metacarpal axis. They're not in the straight line. So this is actually a okay. You could see that picture now. You got this arc 1, which is the radial articular surface, arc 2 and arc 3, or the midcarpal joint on either side. They should form a line. If you do not see the line, you see something missing. And also, X-ray wise on the lateral view, they are not in the linear longitudinal axial alignment. But most important is clinical. See, because clinically the patient would have a very much swollen wrist and very much painful, and might also have some median nerve compression. This patient had some numbness of the index, middle, and ring finger too, and thumb as well. So these things also point to you that you're not treating a simple sprain or a fracture or a dislocation of the wrist. But this patient, after that original X-ray, he had a manipulation under anesthesia and also plastering for 1 month. And this was his check X-ray with plaster on. So it goes to say that even in the post-reduction check X-ray, it is not highlighted, is missed. Can you show it again? Next slide. Next slide. Okay, you could see that clearly the dislocation is out there. So this patient has now 2 months old, neglected, progressive perilunar instability with the lunate, with perilunate dislocation. Is the dominant hand. So how will you manage? What is your option in this particular scenario? Just hear from.
Go for any further imaging to know the viability of lunate, like MRI or.
In this particular patient, I don't think I have done any, because it's actual case scenario. I just went on with surgery, but it is 2 months old now. It is very much, because on the X-ray is enough to give information, which is two things. Number one, I do usually CT scan, but in this particular patient scenario, I haven't done that. I just proceeded. But basically, to look for the articular changes, arthritis, but at 2 months you won't see any. Second thing is to MRI to check the vascularity, but at 2 months I expect that lunate to be vascular. But it is an option as well. Yes, can we hear from Parag?
Influence the decision of what kind of surgery to be done? Occupation of the patient, age demands, will that influence?
Yes, of course. But at 2 months, my question is whether you want to open, try reduction, repair, all these things. Is it a possibility? Because at 2 months you would have a lot of scarring, and when you try to relocate it might be unstable. You might need to reconstruct, repair, sort of thing. Or you want to do limited carpal fusion. That depends on the damage the joint has, or sometimes if the patient comes late, then there is an indication to do corpectomy or arthrodesis. Those things will be influenced by the joint degenerative changes as well as the activity and demand of the patient. So let us see what the other panelists will go in that situation.
Nandan, you want to add something?
Yeah, I think this is not so uncommon scenario, Ram. We keep getting these sort of patients now and then. And I think I would prefer to go and open reduction and ligament repair and augment the ligament repair with some sort of synthetic, suture tape or anything like that. But one thing we should also take a consent on is to take a consent for a proximal row carpectomy, because when we go in, and sometimes the history they give is not very clear on the dates. So you might be caught up when you go in and you see the cartilage is flaking off. Then you should be in a position to switch your operation. So if the cartilage is in good shape, I would still go and do an open reduction and ligament repair.
Yeah.
Anirban, you want to add?
I think these are not very uncommon. I believe I've encountered quite a few of these, and I did present my series in the Hand Society meeting at Ranchi as well. But what I have found is with some of these early on, and I think Professor Kotwal from Delhi, they have presented a series of, published a series of late presentations where they did a staged reconstruction. So what Dr. Kotwal had done was to put a distractor initially and then go down from a dorsal approach and then do a repair with reconstruction. Now, this is fortunate. There's only a perilunate dislocation. There is no scaphoid fracture along with it. And I have often got these patients referred to me after somebody has actually done a CT scan, and that has actually picked it up because the X-rays were not very well visualized or read or interpreted, I would say. So the only other investigation which could be is a CT. An MR, I don't think is really necessary in these, since it is 2 months down the line. My personal preference is to always try and restore the anatomy as well as is possible. But yes, the consent for either a procedure to a limited carpal fusion or a proximal row carpectomy should be taken. And I always counsel my patients that a secondary procedure may be needed depending on the function that is restored. But for a dominant hand, my primary aim would be to do an open reduction, do a ligament repair and or an augmentation to try and get as much stability as possible on day one.
Yeah, I think that's important. What Anirban highlighted that if you openly reduce it, the ligament repair is important because if it's an acute stage, you could probably perhaps some people might consider pinning and let the natural ligament to heal, but sometimes we need reinforcement. But the patient should be consented for option 3 and 4 as well. Yes, Parag, before I show.
Again, these are tricky ones because when they come to you as a final referral, their expectations are still sky high.
Yes.
They finally believe that okay, now you are the guy, and I'm finally with you. But then I think even late. I've been taught by Jim Ross. He told me that you have a fracture. You have a carpal fracture dislocation scenario. Even when you do it acutely in the best interest, in the best way, the risk never comes back to normal. It's never the same again. And doing this at 2 months and 3 months down the line, I have had good X-rays, but not that very good functions in reconstructing these carpus and trying to put them all back together. Yes. At 2 months, I don't think you're going to be able to repair any of the ligaments because it's just going to be a big mush of scar tissue. So then you are looking at internal bracing and sort of ankle repairs or things like that, which again in our scenario is significantly expensive. So for me, in such neglected cases, option 4 is the one that I would go, and I very routinely would do a proximal row carpectomy, and I normally add partial wrist denervation procedures with that. So I would, from the same dorsal approach, I would do a posterior intraosseous neurectomy, and then I incise the intraosseous membrane, and just lying there in front is the anterior intraosseous nerve as well. So I take down the anterior intraosseous nerve as well. So I think for me, This is a good procedure to restore partial anatomy, pain relief, less immobilization, better and early return to function, unless the patient's job is absolutely related to labor, lifting very heavy weights and stuff like that. But vast majority of them, I would do this. If the patient has persistent median nerve symptoms, I would probably do a median nerve release with a counter incision in the palm. So this would be my take on such situations.
Okay. Thanks, Parag. Can you move? What slide is coming up? Oh, see, because as Parag said, finally concluded about the median of symptom, but this guy had absolute numbness of the thumb, index, and median middle finger. So I went first to Oler, approach the extended carpal tunnel incision. So I could just clear. What you see is the lunate, and the articular surface is very much pristine. So it's not much damage or flaking is there. So I just released that, then closed it, and then went dorsally between the third and fourth dorsal compartment. Opened it, cleared all these soft tissue scarring there. Sorry, can you go back to the last slide, Vidisha? Just one slide. So then I just use the relocate back, but the moment you leave it, it just goes back because the scapholunate ligament is totally irreparable. So I just put a joystick and also kept the lunate against the radius. Next slide, Vidisha. So transfix the lunate against the radius with the 1 K wire which is coming from the proximal to distal, and then you have the 2 joystick wire to reduce the handle the scapholunate interval to hold it. So this is the reduction I got it, AP and lateral view. So then I decided to do the internal brace. That's very important to repair this, but direct repair is not possible. This is described for the scapholunate ligament tear. Is an internal brace where you put the first anchor, 2 anchor in the scaphoid and 1 in the lunate. The lunate bone should be good enough to take an anchor. That is important because there is not much chance for if you do it in a thin fragment or thin lunate, it might blow out. So it has to be in the center of the lunate. You take the first anchor in the scaphoid, pass it to the lunate, and that's the first limb. This comes with the tape, and these tapes. Next slide, Vidisha, is taken next to the scaphoid back again, and then fixed it with either a push block or a swivel lock anchor. It is also possible to do this only with the tape, synthetic, or also you could use a small thin graft like palmaris longus in the fork, the tip of the anchor. So this is what I decided to do for the patient. Next slide. So this is perioperative picture of the scaphoid anchor fixation. I just noticed the scaphoid. You see the next slide on the right hand picture, the push lock anchor is loaded to the lunate, came back to scaphoid, and that's the final repair. I also repaired the soft tissue because there is some subperiosteal flap, so you could repair that on the top. That becomes like a scaphocapitate repair. Next is please, and that is the post-operative screening because I used only 1 wire to hold those 2 scapholunate association. So this is the range of movement screening at surgery. So I put the patient in plaster for for a week and then start moving it. And that is the range of movement at 3 months. The patient has some restriction of the palmar flexion and some dorsiflexion, but it's got a good range of movement. I kept the wire on and then allowed him gentle movement of the wrist because I just want to test how good is this internal brace technique in this particular patient. Thank you.
Mobilization protocol?
2 weeks. I think I kept the patient in plaster for 2 weeks and then I started moving gently. And another 2 weeks later, I removed that wire because initially I was traditionally for all ligament repair scapholunate area, we put a wire to hold it. So I was just putting the wire to hold it. I could have, but then I just screened it. It was pretty stable, but I was off-minded whether to leave it or not. So I just left it for 4 weeks. But I think after that, when I did scapholunate reconstruction, I do not use any wire at all now because that is quite stable because it's intraosseous to intraosseous repair. So it doesn't let the bone to go away from the fixation. But as Parag pointed out, it is inexpensive because it is involves use of 3 anchors minimum, sometimes 4, And then second is this, the bone quality should be good. So if I totally agree, if the patient comes in a bit later, I would not hesitate to go for the option 3 or 4. Also, when the lunate is damaged, I mean the cartilage is flaking, then if you relocate and repair and spend all this money, then the patient might become painful. So, thank you.
Very well done. So if the patient is non-affording, what will you do for that case?
Proximal row carpectomy.
Yes. Simple operation.
Coming to a case shared by Anirban. Please proceed.
Okay, we had a 17-year-old boy who presented with a left-sided wrist pain for almost 6 to 8 months when he came to me. It was his non-dominant hand, which he had injured while playing football, and was initially treated as a wrist sprain. So next slide, please. So this was the X-rays. At about 4 months post-injury, when it was still not improving, somebody got an X-ray done, and this was what the X-ray looked like. So this was a proximal pole fracture of the scaphoid, and then somebody said that he needed a cast, needed surgery, so he was roaming around not knowing what to do. Then by the time he came to me, it was another 2 months, so it was almost 6 months when I saw him, and that's when the next X-ray. Next slide, please. So this was the X-ray when he came to me at 6 months. Now you can see that as compared to the previous X-ray, there is a little more gapping at the fracture site and a little bit of early cystic formations as well. But thankfully, no arthritic changes in the radioscaphoid joint. So this is the situation in which he presented to me 6 months post-injury, scaphoid non-union of the proximal pole. So how would we proceed?
Ram?
What was the opinion of our panelists?
Yes, Ram.
Yes, so this is a 6 months old non-union closer to proximal pole of a young chap. So this needs surgery. In principle, he needs. I would get a CT scan. Do you have the pictures available to check for the humpback deformity? It's got any volar wedging deformity, because that has a criteria for me. If there is a wedge back or a humpback deformity of the scaphoid, my approach, that decides the approach to go for polar wedge-shaped iliacrust graft, because I believe in corticocancellous graft, and then a fixation from polar approach distal to proximal with a headless compression screw. If the CT scan shows an in situ non-union with no much vascular necrosis now, and there is a possibility for me to do the approach from dorsal percutaneous with the antegrade headless compression screw fixation, with adding of cancellous bone graft from a limited dorsal approach. That could be controlled by arthroscopy assisted. So that will be my approach.
Dr. Kanjan, want to add?
Yeah, I think
anything?
Anirban, I think do you have an MRI of this?
Yeah, actually he came to me with an MRI done, which we'll close. But just going for the rest of the audience, this is actually a Slade-Geisler type 4 non-union based on the X-ray alone.
Yes.
Where you can see there is a bit of cystic formation, there is minimal sclerosis. But if you look at the lateral view, there isn't an obvious humpback deformity. The lateral view shows that
it doesn't look like
doesn't look to be a humpback deformity.
Because many a times when you have a proximal waist fracture, which is almost near the proximal pole, the humpback deformity is not so much. But if you have it in the mid waist, the humpback deformity is more.
Much more.
Yeah, so there you go, volar. But for this one, I would definitely go dorsal. I would think of ICBG, iliacrest bone, the intercalated vascularized bone grafting with a screw going from proximal fragment to distal fragment.
Okay. Can we have the next slide? Probably the MRI is there. So before we go on to that, so these are the diagnostic dilemmas which we face normally. That do we need any further investigations? the commonest question which the patients ask is whether this can be treated conservatively because he's not had a trial of any cast. Does it really need surgery? If surgery, what would be the choice of implant? Will in situ fixation suffice? And if a graft is needed, whether we would go for a non-vascular or a vascular bone graft. So those are the points of discussion. So this was the MRI with somebody else. He had got done, somebody had suggested, and this is what the MRI shows. So, Deepthi, Ram, your comments on the MRI?
There's just definitely a cystic changes there, and it is on. This is the T2 weighted image, and you can see it's totally dark.
Yeah.
And I think you do have an element of avascularity in the proximal fragment.
That's right.
So I would stick with my plan.
Okay.
So I think,
Parag,
yeah, so I find MRI is not, the best
Yeah.
investigative tool for this because it doesn't help me plan my surgery as much. So in my practice, even when they come with MRIs, they still go and they still go for a CT. And then depending on my findings of the CT, I would plan my approach and everything. So sorry, but I find MRI is not that helpful in staging, grading, or my approach and the kind of fixation.
Yes.
Considering the fact that this fracture is just proximal, sort of proximal to the waist, and with potential changes, there is still the dilemma as to whether to go with vascularized grafts or standard cancellous grafts and fixation. But as I said, I would still get a CT and take a decision, and also important are the other views, not just the axials, to decide upon the final plan to fix this fracture.
The second thing is that even if the MRI shows some avascular changes, you can still do a successful iliac crust graft as well.
Yes.
With the healing of the scaphoid non-union. So it doesn't actually dictate you to do. Is that your experience, Anirban? What is your comment on it?
No, it's a very valid point which I wanted to raise actually. Well, this concept of avascularity of that proximal fragment itself is quite debatable.
Yes.
Whether you label it as avascular only on the MRI features or you do it on table. So there are papers which have said that only the MRI should not be the criteria. You should augment that MRI features with what is found intra-op. And intra-op, if you find that fragment to be avascular, that means even after doing a good debridement using a burr and you still don't get complete bleeding.
Complete bleeding, yes.
Yeah, and even after that, if you should ideally deflate the tourniquet and then check. So after doing all these things, if still the fragment is avascular, then it should be actually labeled as avascular. Some papers have even recommended doing a biopsy from that segment and to confirm that. But this is just for the rest of the audience. The proximal fold vascularity is tenuous, and even the AO recommends fixation even if it is primarily. So coming to implant choice, we have the headless bone screw like Deepti mentioned, but depending again on the fragment size, if it's really too small, then you could use only a very mini Herbert screws or just some K wires or a combination of the two depending on what you get as to the size of the fragment. And as regards the entry point, yes, it should start very close to the scapholunate ligament, and you go from dorsal to the from the proximal fragment into the distal fragment. And it's important that the thread should cross the fracture site so that and should not lie within the fracture site. And the measurement of these screws should be adequately done, and you subtract about 2 to 3 millimeters to get the actual size of the screw. It should be entirely within the bone, and it should not lie even prominent. So next slide. Yeah, so I went ahead and did the supraretinacular artery vascularized bone graft because in short I found that it was not bleeding well. And this is the slide where the graft has been slotted into the non-union site, and I fixed it with the headless bone screw. So that is the post-op X-ray. You can see And by 6 weeks, this is how he was progressing towards union. And, and by 6 months, it had shown very good consolidation and the carpal anatomy, and that's the sort of function he got at 6 months. He's still a little short in his flexion, but his functional evaluation, the scores were quite good, and he's been advised to do further therapy to get it further improvement. So the learnings from this case was, one is that you need to know the classification of the non-union so that you can adequately classify that what sort of a non-union it is, and then decide, like all our panelists mentioned, CT would guide you. If there is a humpback deformity, then you could go volar. Regarding the choice of grafts, you can do both non-vascular as well as vascularized grafts. Within the vascularized grafts, you can take grafts from the volar side as well as from the dorsal side, both from the metacarpal base as well as the volar one, as described by Mathula et al. So the take-home message is that the proximal pole scaphoid fracture is different from other scaphoid fractures. The risk of AVN and non-union is high. Determination of the AVN itself is still controversial. In the acute setting, fixation is definitely preferable. And in the delayed setting, it is always fixation with a graft, vascular or avascular, which you can decide on table after looking at the fracture itself, the non-union itself.
My question is, what is the decision criteria to go for vascularized bone graft?
Yeah. So as I mentioned again, MRI corroborated with your intra-op findings should be taken into consideration to decide a vascular or an avascular graft. So that would mean that you open up the non-union site, thoroughly debride it, burr it out, and see if there is no punctate bleeding. Then you can decide that you'll go ahead and do a vascular flap. If you get punctate bleeding, then like Dr. Ram mentioned, you can do just a good quality iliac crest bone graft, but be sure to fix it properly so that you can get a good union. Some people have described that you can temporarily offload the scaphocapitate joint by putting a pin across so that the proximal pole gets offloaded temporarily. So that has also been described.
Yes.
Technical tip, whether you put screw first or graft first.
Well, the original descriptions were always to put the screw first, get the screw inside, and actually cut a slot out on the dorsal aspect of the scaphoid, partly on the distal fragment, partly on the proximal fragment, and the graft should be a snug fit into that slot. That itself should give the stability. The graft can be fixed with screws or K-wires, but I have often not found it necessary. The measurement of the graft and putting it back and just gently tamping it inside makes it stable enough.
Yes.
Is there any risk associated of graft dislodgement?
Yes, it is. That's why the measurements for the graft, it's a little fiddly, but the measurement of the grafts while raising the graft, that needs care, and the slot cut should be adequately matching the graft, and then as you gently tamp it inside with a bone punch, when it's fixed snugly, then it remains.
Do you require radial styloidectomy to widen your exposure anytime?
So far, I haven't had the need to do that.
Any other panelists want to add? So my question is
when
the
you use the
supraretinacular artery graft giving consistent results? Why there was need to shift to medial oral condylar free vascularized graft?
Right. Very good question, Dr. Vidisha. Actually, what was found with most of these proximal pole fractures, when the medial condyle free vascularized graft came up, that is more indicated for the classically avascular ones and ones which have already been intervened previously. And means somebody has already tried a maybe a non-vascularized graft, and then you are left with hardly anything. So those are the places where. But there are papers which have shown that the medial condyle free vascularized graft gets better union rates as compared to even the supraretinacular flaps.
Ram, you want to add anything?
Just one point. When you use the iliac crust graft, I take a slightly larger, slightly thicker iliac crust graft, put it in between, impact it, and then use the graft as well to incorporate into the headless compression screw fixation. But I totally agree. When you do vascularize the graft, you have to be gentle. You have to put the screw first.
Dr. Nandan, you want to add something?
Deepti, you're unmuted. You need to unmute yourself.
Just one technical thing I wanted to know from your dorsal grafting. So when we put our graft from the dorsal part, when you're doing the dorsal approach, are we actually increasing the length of the convex side of the scaphoid when we're doing this? And will that have an effect on the wrist kinematics?
Actually, in this case, because there was no humpback sort of deformity, so the length of the scaphoid was, as you saw on the X-rays, was well maintained.
Yes, yeah.
So I just had to cut a slot dorsally and get the graft to sit in place. By which, since the length of the scaphoid remains unchanged, the carpal kinematics is unlikely to be any different.
Because that is one of the worries I have whenever I do the dorsal grafting. Because you impact it in and then you see it's gone. And
You cannot disimpact.
Yeah.
It was a very well done case, Anirban. So now coming to next case by Dr. Parag Shah.
Yes, so again, these are pretty tricky fractures, and the title was that is this just a simple comminuted radial head fracture, or is it something more to this? So vast majority of radial head fractures, when you see just on the X-ray, you take a call on what to do. However, there is more to this injury than what meets the eye. And as is been published in the literature, that a comminuted radial head fracture is seldom isolated. So there is always something which gives way. So and this could be anything, any of the three structures, apart from other bony injuries which may coexist, is a lateral collateral ligament, your medial collateral ligament. And don't forget that the elbow, the wrist, and the forearm is one functional unit. And there is also longitudinal stabilizing structures, and that's the interosseous membrane. So any of these three can give way depending on how the injury occurs. So this was a case of a 28-year-old guy who fell off from a 20 feet height, from his terrace down. So this was a classic case of, an elbow which was axially loaded. And this led to a complete shattering of his radial head. But what is more important is also, if you look at the X-ray below, of course, it's a tiny image, but that the radius is not aligned longitudinally as well. So if we, can you put in the next slide, Vidisha? Right. So it's always important to see what's happening on the entire forearm and especially at the wrist as well. So this guy, when he was referred, he said that, he never even complained of the elbow. He just said that my wrist looks wrong and I have pain in my wrist. So that's when you look at this and you decide that there is a disruption of the distal radial ulnar joint as well, and the radius is significantly short. Now, this can only happen if there is a significant axial load which transmits all across the interosseous membrane. So this is, can we have the next slide? So this is the classic, the eponymous title of Essex low Presti injury. And nowadays, a lot of people prefer to call it the acute longitudinal instability of the forearm. So this is how it looks in the entire spectrum. There is a shattered radial head. But the point that you can even look at the CTs, especially in the lateral image, is that the the radial head is fractured and the end of the radius is actually abutting the capitellum. So So this indicates that this radius has shifted proximally. Okay, and apart from that, there is a very small coronoid chip avulsion, but the rest of the elbow anatomy is quite normal. So this brings us to the age-old debate, of not excising every unfixable radial head fracture. So this is almost an absolute indication of either fixing this radial head or replacing the radial head. And as you see from the images, that this is virtually not fixable. Next slide, Vidisha. So again, for this is a compelling indication for replacing the radial head and restoring the radial length. As you see here, what I've tried to highlight is that the mechanism of injury in an SF clopresti is quite different from a terrible triad where you have local ligament injuries which predominate. But here in this situation, the collaterals are intact, as you can see, and there is significant muscular damage around it. So this radial head was the pieces were retrieved and excised, and a primary radial head replacement was done. There was significantly good stability of the elbow, so the small chip avulsion of the coronoid process was not dealt with. And this is the intraop image where you have excellent reconstruction of the PRUJ, and this is after the image on the left is before, and the image on the right is after replacing the radial head. So even the distal radial joint anatomy has been restored. And now it is the tricky part as to what do you do to the intraosseous membranes. So we took international opinion on this, and varied opinions came in where some people were in favor of acute reconstruction of the oblique band of the intraosseous ligament, either with the help of a pronator teres or like a double endo button kind of a construct. But here we went on for the simpler option, which was to pin the radius and the ulna in the neutral rotation. So these were the options of the whole treatment: radial head fixation or replacement, addressing the distal radial joint, and radio-ulnar pinning, intraosseous membrane reconstruction with pronator teres or endo buttons, and high-strength sutures can be done. But the whole idea is to recognize this injury and treat this as a complex instability and replace the radial head prima facie when you cannot reconstruct. And any questions so far, Vidisha? Any comments? Because this is the sequelae of what happens when that has been missed. So anything any of the panelists would want to add or question at this point in time?
Why a mid-prone position for radio-ulnar pinning?
So again, I think that position is from the patient's perspective quite simple to maintain, and so we permitted early active range of motion of the elbow with just the forearm in a mid-prone position. So that was the only reason to do that, because so that we could it's easier to mobilize the elbow in that position.
So when was the wire removed?
6 weeks.
6 weeks. So do everybody put radio-ulnar wire in mid-prone position? All panelists?
Yes.
Yeah.
All put in mid-prone position.
Because it's very functional, you can still mobilize the elbow, the patient can still reach his mouth, head, and still do a reasonable amount of function with that, including holding things. So if you immobilize in supination, it's still difficult to do certain activities, and so same in pronation. You don't do in pronation because then your radio-ulnar relationship is a little bit altered,
Yeah, I think isolated Galeazzi fracture dislocation with the DRJ is a different bottle of thing, and there you put in supination. But here we are maintaining is an axial length correction. So
that's
after
right.
done the radial head replacement or fixation, your length is restored. All we are doing is to maintain the length so that the DRJ heals on its own. So I totally agree with the mid-prone position, which is more comfortable, as well as you can regain movement on both sides.
True.
And
So again,
the most important thing is to ask the patient to whether he has pain in the wrist.
yes.
Otherwise, it tends to be missed.
So, and what happens when it is missed? So this was another case which I just added here to as a continuum of when this injury is missed initially. So this was a very young guy in his mid 20s, and he had an SX low press injury which was missed. He had the radial head excised as a delayed procedure. After that, there was some sort of pinning around the elbow, and at 13 months, he came to me with hardly any motion at the elbow, which was very stiff because of prolonged immobilization for a variety of procedures that he underwent. And he also had a lot of wrist pain because, as you see, the DRUJ is completely disrupted, and he also had loss of supination. So this is what happens when something very fundamental is missed, that is not assessing the distal radial joint in the forearm with a radial head fracture, and then going ahead and excising the radial head, considering that there is no other injury around the elbow and there is no dislocation. So this patient now has a very arduous path in front of him, and even for a surgeon, for me to offer something that's going to help him was also a bit of a problem. So what we decided was, I asked him what is his most prime complaint, and he said that was the stiffness at the elbow. And so I said, you know what, we're going to do an elbow release on you, and let me see if I can replace the radial head at this time, and things going well at the elbow, and then we'll do a delayed procedure at the wrist. So we agreed upon this form of management. Next slide, please, Vidisha. Right, so this is what we decided. This was my approach again from the posterior side. I do a 360-degree elbow release. This was the size of his very thick hypertrophic capsule because of prolonged immobilization. And next slide, please. So this was the video, but it's not going to work here. But he achieved excellent motion at the elbow. So it was almost fixed in 90 degrees. But now he was able to reach the shoulder, and he was able to eat as well. So then he went away, and I thought, what, this is it. But then he came back 1 year later saying that, okay, now it's time to deal with my wrist. So again, now it's almost nearly 24 months since the time of his initial injury. He has pain. The distal radial joint is obviously dislocated, and he has DRUJ pain. So Ram, or maybe Anirban, what is your what would be your take now for his wrist?
Dr. Parag, the elbow looks great. You didn't manage to replace the radial head at that point.
So let me tell you that. Sorry, I forgot. There was absolutely no space. That radius would not budge. It would not go distally. I could not manage it to even move the stump of the proximal radius where the head was excised to put in anything whatsoever. So that is how tight it was, to be honest. And I did not put the radial head, also for the reason that there were already some cartilaginous changes on the capitellum from the radius end of the radius abutting the capitellum for a long time.
Right.
When you go in a delayed situation, it is often the do the radial head replacement.
Absolutely.
You're worried about the.
We had everything ready, but I wasn't successful in doing that.
Equally. Now, question is whether how much good is the ulnar head viability? So I will see. You need to have some imaging, or just have a look at, is it showing arthritis? I can't see on the X-ray clearly. If the ulnar head
it does look arthritic.
Yeah, if the head looks arthritic, there's got only two options in my practice: either to have a soft Kapanji type of procedure to restore the DRUJ and then do osteotomy of the ulnar above to get the rotation. The other option is a radio-ulnar replacement, but we do not have it in India yet. So
we still don't have the Shekhar kind of prosthesis.
Prosthesis is ideal for this young patient to get the rotation back. But without that, I would just do a soft Kapanji procedure here.
Okay.
But if the ulnar head is intact, there is a possibility of shortening osteotomy of the ulnar and then try to restore whatever TFCC ligament, TREJ joint factors are there to support it.
Okay.
Yeah, I think I concur with what Ram is proposing. Depending on what is the status of that radial of the ulnar head, You can either try and relocate it with a proximal ulnar osteotomy, shorten the ulna. Otherwise, it is better off to do a salvage procedure. A Saukapanji would be useful in this young individual.
So again, the problem with the Savi Kapanji is that the axially the ulna is significantly long.
Yes.
So how are you going to get it back in place
Take
to
a big
do a
segment out.
DRUJ fusion?
The alternative option is to just do ulnar shortening osteotomy and just leave it.
Right. Okay.
Let him move with whatever else.
Yeah, the thing is, see, you should remember that this is a 13-month-old injury.
Now
He
it's
already
nearly 2
had-
years.
Yeah, he's already had osteoarthritis in the elbow. Okay, that means the radial radius is not going to move any further. So the only thing you have variable you can change is the ulna.
Ulnar.
So I would go for a ulnar shortening osteotomy in him. And in fact, it's very interesting to see that he has ulnohumeral arthritis, which would suggest what Joe Cooley used to say, that radiocapitellar problem, if you have, you get ulnohumeral arthritis. That is why he used to do radiocapitellar replacements to
Yes.
prevent any further damage. Okay, so that's beside the point. The second point is that whenever you have a longitudinal instability like this, like an SS lopristi, there is a saying that the SS lopristi lesion never heals. That is one of the reasons why people suggest that you use an augmented reconstruction of that ligament with a
Right.
hamstring and other things. But we do this, you have done this radial head replacement and you have done the stabilization of the radial ulnar joint. Did you notice that these patients, did they come back with any pain later?
No, so it has not been a very long follow-up. This patient, these are two different cases, okay?
Yeah, I know. I'm just trying to.
No, so the first one, is staying in a village very far away. So he hasn't come back since his 3-month visit.
Mhm. Because they will have some pain in the forearm and the radiocapitellar joint later.
Yeah, it would be very interesting to assess him further. So we'll probably send him some message and get him back at a year's time.
Okay.
Right. Anyway, so next slide, please, Vidisha. So this is what we did. So there was the ulnar head was completely arthritic. There was ulnocarpal impingement. So we went ahead and I did a matched resection interposition arthroplasty for his DRUJ, and we did a significant shortening. So it was more than almost a centimeter and a half of shortening of the ulna, and then fixed it with a plate and grafted the osteotomized bone around it. And it's quite amazing that his wrist pain vanished very soon after the surgery. I ideally would have wanted to give him an above elbow immobilization after this, but he was absolutely vehement, with his stiffness of the elbow, that I am not going to immobilize my elbow whatsoever afterwards. So we put him in a below elbow splint, and it took a good amount of time for. Can I have the next slide, please? For this osteotomy to actually heal. But now he has no wrist pain, but now he's a little bit bothered because of his wrist stiffness. He wants that restored as well. But as of now, we have no plans to do any further surgery on him, and I am persisting with therapy. But the good part is that his elbow is moving and he is pain-free at the end of 24 months of an arduous journey. So just to highlight an acute case of SX low-presti and a chronic case when things go pear-shaped. Thank you.
Parag, for very nice cases. This case is shared by Dr. Dipti Nandan. Please go ahead.
Yeah, this is an interesting one. It's a priest who is 42-year-old, fell off a bike, and he had abrasions and superficial degloving of whole of his forearm and elbow, but neurologically intact. Next slide, please. So this was the picture. I don't have the X-ray on him because he came with an outside X-ray, and the only thing I got in my system was a CT scan, which I got done. And the things I had noticed on the CT scan is that there is a fracture of the medial mass of the distal humerus with a radiocapitellar and ulnohumeral dislocation. And one important thing I have noticed on the CT scan is that there is a sliver of bone on the lateral ulnar collateral ligament attachment. That is where the I think the annular ligament and the lateral UCL is attached, and even that sliver of bone suggests that there is elbow instability in addition to the medial mass fracture. So, what are the options? What are thoughts going through various panelists? If you would just know.
Anirban?
The X-ray and the CT can often lull you towards being a little unsure. But like Deepti has already mentioned, that there is a lot in this which needs to be taken care of. So apart from the entire elbow subluxing medially, along with that chunk of the medial condyle, it's almost entering into the trochlea. So that has to be taken into consideration. And whenever you have an injury like this, usually the other ligaments are also damaged. So one should not be thinking that it's just a condylar fracture and I'll just fix it and that should give the enough stability. After fixing that, one has to check the stability on all sides, and if required, ligament reconstruction has to be done simultaneously.
I think that's very important to. Hello?
Yes, we can hear.
I think it's very important to recognize that radial head is out of alignment with the capitulum. At any view of CT or X-ray, lateral view, at the projection, it should be pointing towards the capitulum. It is not. That indicates this is a sort of interesting case because it's a rotatory instability of elbow. It probably would have ruptured all the lateral ligaments, everything. But then the final bit of it, rather than the ligamental injury on the medial side, it has maybe the brunt of all, it has taken the entire condyle. So it's a combination injury, a distal condyle fracture with elbow instability. So it has to be addressed both.
So, yeah, Parag?
Yeah, so again, complex injury with sort of a dislocation as well as this condylar fracture. I had a case where there was also an entrapped ulnar nerve at the same time. So I think that also needs to be assessed. What's the status with the ulnar nerve as well? Because sometimes people have attempted close reductions with the ulnar nerve entrapped within the elbow joint. So yeah, I agree with all the other thoughts. And as I said, an added complication can be an incarcerated ulnar nerve that would also need to be looked at clinically and sort of intraoperatively as well. But yes, I think we would like to see what Dipti did eventually.
I think one of the questions on the chat was, why not MRI? But in this particular case, I am not too keen on going for MRI because if you look at the distance between the medial epicondyle and the ulnar, that is not changed. That means the medial side ligaments are intact. The lateral side, that there is a sliver of bone going off the ulnar. That means the avulsion is from the distal part of the lateral collateral ligaments. So then how to approach. Then the next question is, how do you approach this injury? You go for a medial approach or you go for a posterior approach? Can I get an opinion on that?
Posterior for me.
Okay.
Ram?
Medial and lateral.
Okay.
Yeah, I would do probably both, medial and lateral.
Okay. So I chose to go with the posterior approach because one, for me, ulnar nerve decompression and isolating the ulnar nerve is very easy for me from the back. One. Secondly, I can approach both the medial and the lateral problems through the same incision. And fourthly, when I put the plate on, I can easily visualize the whole of the trochlea and the plate very well when I'm going through a posterior approach. So that is the reason I went for a posterior approach in this patient. Do we have the next slide? I don't know if the intra pictures are there or the intra pictures are not there. Okay, fine. So the degloving part of it, we just did dressing because the subcutaneous plane was intact. Only there was abrasions on the skin. So we did a collagen graft for the skin. And first I reduced the condylar fragment back on and fixed it with a separate screw. And then used like a buttress plate from the medial side to hold whole of the fragment down and also have one screw going right across to the intact part of the humerus. So you have a good compression across the fracture site too. And once this is done, I went back to the radial side and fixed the radial sliver with anchor and the sutures passing around the detached fragment. And this is the image after surgery. This is around, I think, 3 months follow-up. I don't have his post-operative clinical pictures with me because I couldn't find them where they are. Sorry. But
Since
he had full range of motion in the elbow except for final 10 degrees of extension. That is one thing I have noticed is a problem in most elbow injuries, and I think it is probably the anterior band of the medial collateral which becomes tight and gives you that stiffness.
my question is, since you repaired the insertion part of the LUCL,
Correct.
did you protected the repair for 3 weeks, or you started
No, I start mobilization immediately.
even if you use anchor?
Yes. Now there is always this care about giving you instability when you are mobilizing this elbow. But when an elbow is mobilized in this fashion, the collaterals are not under too much stress. So even in my reconstructed elbow, collaterals, I still mobilize them early, unless you give it valgus and varus forces. So especially when they come for dressings, you never hold an arm like this and then do a dressing. You should always have it in this position so they don't bend it this way or that way. So you're not getting any valgus or varus stress at the elbow.
Suppose if you do neglected dislocation and you do both the MCL, LCL repair, even then your protocol remains same, or you protect the repair?
Yes, I actually keep extension blocks splint and make them flex further. So they are still mobilizing them and loading the ligaments as well as keeping the joint moving rather than keeping it completely stiff.
Ram, you want to add something?
Yeah, I agree. In my practice, if you do a stable repair of the collateral ligaments or the fracture avulsion, you are making it a stable elbow again. So there is nothing to stop you from mobilizing the elbow as comfort allows. But if you are actually treating some of the injuries partially conservative, means partly repairing it, in that scenario, you could just put them in a brace. That will give collateral stability and still you could move it. But when you have a fixation or repairs and you are confident with the strength it provides, you could mobilize. I normally keep them in a supportive sling only and then just get them moving. As Nandan pointed out, it is the position of the elbow in day-to-day use is much more important, not to let it go sideways. But regular use doesn't damage the elbow.
Case, sir. So we proceed to Ram's case.
Okay. Let me just see quickly. I think we have only less time. So 26-year-old man, 3 months after cricket ball injury to his index finger, right-handed. So that is this set of X-rays. He came actually with the first set of X-rays and the extreme left AP X-ray and an oblique X-ray, and was treated as a sprain of the index finger. And this is the right two images or the X-rays which recently had been done that shows the problem actually much more. So this is the injury which is 3 months old. So I think it is recommended to have a CT scan. I hope the panelists will agree with that. Can you go back one slide? If you see, that injury is the fracture, proximal interphalangeal joint fracture dislocation, with the dislocation of the base of the middle phalanx dorsally with the comminuted fragments of the base which is displaced. So this is an injury where in my practice, if it is coming at later, I would just get a CT scan to assess the extent of articular damage as well as the evidence of arthritis to plan further management. So that is the CT scan findings, and this is the classification Eaton's type. So this comes under unstable with about 30 to 40% damage to the articular surface with the persistent dislocation dorsally. So So what will you do? Just have a quick panelist opinion on what is their preference at the 3 months post injury on this one. Quick.
So I would go for a volar plate arthroplasty here.
Yes. Okay. And your approach would be volar, and then you try to repair the volar ligament, excise the small bony fragments.
Yes, excise the bony fragment. Go volarly, and initially, long time ago, would use a button on the dorsal side, but now
Yes.
I would probably just use a suture anchor.
Suture. Okay. Nandan.
I think I'll prefer to go for a volar plate arthroplasty too.
Okay. Anyone?
Yeah, I'd rather do a hemi-hamate.
Hemi-hamate.
Hemi-hamate seems to reconstruct it better, and you can. It's a young individual. It'll give more stability. They do end up with a little bit of a flexion deformity, but that can usually be stressed out.
Yeah.
So, my preference would be for a hemi-hamate at this stage.
Okay. So I think the CT scan telling you that the extent of damage. Do you have any cutoff for this hemi-hamate arthroplasty? Because you need to have a good bone on the remaining middle phalanx to fix this graft too. Any cutoff for you to do hemi-hamate? Anyone?
I would assess the cartilage intra-op and then decide.
Okay. And if at all you open and do the hemi-hamate, you open the finger first, you have a lot of damage. What is your backup procedure?
In the backup, then you would go for a volar plate arthroplasty. But either way, whenever you get such a bit of damage, you are not going to get a good function no matter what you do. So
I think so.
I would, because he's a young individual and he's been playing cricket, so my first option would be to try and restore that articular cartilage as best as possible. So I would go in with the idea of doing a hemi-hamate, yes. But volar plate would be the fallback choice.
And if the situation is not good, just go for the volar plate. And very, very occasionally, you might need to warn the patient, you might end up doing arthrodesis with the PAP joint as well, just in case. So as explained, I just went with a plan of hemi-hamate arthroplasty. We just take a dorsal chip of the hamate with the articular surface perfectly congruous with the plane of the base of the middle phalanx. So that is ideal choice for this grafting procedure. Is a osteocartilaginous bone grafting, so that fits there. So sorry, shotgun approach. Actually, you go through the semi-prunar incision, A2 to A4 pulley divided. That A2 and A4 pulley are preserved. Remaining portion is divided. Tendons retracted. You have to cut the transversely cut the collateral ligaments, and there you expose, like opening a loaded shotgun to load your bullet. So then you make a cut, make a proper receptive area. Then I normally do this with the identification with the guide wire to check exactly which position I want, make a small longitudinal incision, and then you have to push the metacarpal down, and you go so that the saw go parallel to the metacarpal plane to get a small piece. There is very small piece only you take, but you have to measure and take the ideal graft size. Then you get the graft fixed with 1 or 2 screws. Here I used 2 1.3 millimeter hand system screw. So that shows the fixation. That shows the restoration of anatomy. As Anirban correctly pointed out, you would not have very much full straightening, but what we are aiming is to get the flexion of the joint. Next slide, Vidisha. No, the previous one. Is there a previous one slide? Oh, this is the one. Okay. So this is that surgery. If you see that is a volar plate. 2 screws could be seen fixing the graft, and that is the range of movement the patient has post-op. As soon as you restore the PIP joint, it's got a good about 10 to 100 degree flexion of the joint. Then what I do, that's a bending and that's a straightening. Now what I do is that it's just advance the volar plate, and you could suture to the, you can put an additional anchor to suture it, or you can suture to the collateral ligaments on the side. So that gives you some extra stability. So post-operative, I put him in Edinburgh splint for 10 days to get the swelling down, because it is a big operation for the finger, and then start mobilization. Okay. So go, is there one more picture? No. Oh, the final outcome picture is missing. Okay. So he's got a reasonable good flexion. There's the flexion deformity of 10-15 degrees, but he's got a good flexion up to 100 degrees. So just to highlight that PIP joint chronic injuries could be treated by slightly different approach, either to do a hemihamate arthroplasty if it is possible, and if it is not possible, you could always do a volar plate arthroplasty. Thank you.
Any technical tip how to put the screws? Any risk of shattering of the graft?
It had to be, I think the main thing is to put a smallest screw possible. If you don't have that, you have to get it. It's like a 1 millimeter screw or 1.3 millimeter screw. And better than putting, I always put 2 screws, because if you put 1 screw, it might split. But if you do 2 smaller screws of 1.3 millimeter, that will hold the graft better. And the worst case scenario, if it is shattered, you have to be prepared always for volar plate arthroplasty. Thank you.
Any other point to be added, Anirban?
No, very nice demonstration, Ram.
Thank
No,
you.
no, it's absolutely nicely done. So that's about it. I think we can go ahead and take the audience questions and wind up. We are short of time.
So we will rush through the last case. Anirban, your case.
I think, Vidisha, we can skip the last case and just take audience questions. I think we are short of time.
Sushrut?
Already people are getting impatient about it. So
Exactly. I think we can skip the last case and just take the
so
audience.
some of the very fantastic cases actually. So there is a doctor who is asking, Dr. Ashwini Prakash from Trivandrum, who is asking, he has a patient who has a myositis ossificans and only restricted jog of movements. What do you suggest? So myositis ossificans, cause of stiffness. Dipti, you want to take this? What is
Yeah,
your take on this?
myositis ossificans, it depends on the age of the myositis ossificans, in the sense that early or late. And if previously I always used to think that we should wait for the acute inflammatory stage and then go ahead and excise the myositis. But now, after listening to actually a surgeon from Coimbatore, I think I have actually changed my mind on this regarding the timing. And if you feel that there is the warmth on the elbow joint is reduced, you can go and take it out even at 2 months, even at 1 month also. But HO excision done early on probably is giving good results than doing it late from the series he had presented. That is something new I had learned, but from practice point of view, I have still maintained my traditional way of doing it after 3 months.
Sure.
And
Perfect.
the approach to it is quite an extensive approach. I go through a posterior approach and do it. And Parag has a much more extensive way of excising it, and he will explain that. But it will be interesting to hear from Parag as well.
I think one thing to mention, this the question is like the patient has 80% of movement of elbow. If somebody has got 80% of movement of elbow, I would not recommend anything to be done additionally, because you need only 30 to 100 degree for day-to-day function. Some profession might be full straightening, but 80% movement is okay. And the second thing to mention is that I would look at articular incongruity. If the elbow joint is not congruous, I don't worry about the extent of atrophic ossification. I would go in and explore and do the surgery. But otherwise, I totally agree with what Nandan's views. Lesson from Parag. Thank you.
Parag, you're mute. Parag, unmute.
Yeah, sorry. So I sort of moved to early excision, and I have to say that the results were not very rewarding, in the sense that more than 50 to 60% of my patients had recurrence of HO when I operated them within a certain time frame earlier than 3 months. So now what I do is, yes, the local warmth, etc., is fine, but I think on the X-ray, if it still looks like a cancellous bone, the HO around the soft tissue is cancellous in appearance, you still have to wait. I wait till it looks cortical. Okay, and when you excise that, it has to look like cortical pieces of bone and not the mush that you normally take from maybe from your iliac crest when you're doing a cancellous bone grafting. So I think that has taught me to wait for a little longer. I still do CRPs and alkaline phosphatases, and I wait for all the parameters to come back to normal after my experience with excising early and getting recurrence of HOs in quite a few patients. So I again wait till at least beyond 3 months. Most of the patients come to me between a waiting period of 4 to 9, 10 months. And then again, you have two sets of people, one who have pure osseous injuries and the ones who have brain injuries. So again, there is a neurogenic heterotopic ossification. NHO is a big topic by itself. But in the treatment sort of still remains the same, because number one, you need to understand that HO happens in between muscular planes. Number two, the capsule is a great barrier to actual ankylosis of the joint, and it takes a very long time for the calcification to go across the joint. But anyway, coming to treatment, again, most of these can be tackled from a posterior approach, but it all depends on where the HO is. So the HO can extend from the humerus to the radius, and if that's the case with a like an C-shaped bar, then you go lateral and excise it. However, if it's global, then I choose to do a posterior extensile approach. I split the triceps from the center, take it down on either side, take down the HO from the posterior side first, do a complete capsulectomy, and then flipping the arm medially and laterally. I even take off most of the HO from the front, also from the same posterior approach. But again, you need to understand that this can be global. Everything cannot be done through the same approach. You may have to stage it. You may have to take multiple approaches. Sometimes the HO engulfs your neurovascular structures. You can see nice holes in the CT scan where the vessels are going, the nerves are going. I've had quite a few cases with the ulnar nerve encased within the HO, and just one case where the anterior, the brachial artery and the median nerve were actually traversing right through the mass. So I think all these factors need to be considered when you are excising HO. But I completely agree with Ram that if somebody has 80% of the range of motion, then I don't think there is any point in trying to do an extensive surgery to achieve a little bit more.
Perfect. Perfect.
Right.
So I'm just going to jump on to the next question, please, for want of time. So this is another question again from Rajkot. Dr. Ketan Sutra is asking if there is a fracture scaphoid conservatively treated 3 months, proximal fragment now is showing some AVN on X-ray. Any suggestions? Ram, do you want to take this?
Yes.
So 3 months conserved, now showing some AVN changes. Let's talk of West level.
As we talked about, I think 3 months, I wouldn't bother about diagnosis of AVN in scaphoid fracture. I would proceed as it is like a fresh fracture, because I'll just go with whatever plan I have. It's a proximal pole. My majority scaphoid fracture, I go with the proximal to distal direction, dorsal approach, percutaneous, with the headless compression screw fixation. And at 3 months, I do not immediately rush to do any grafting unless it is absolutely necessary.
Okay. So next question is from Dr. Gopinath. After an ideal fixation of non-union proximal pole, how many of them develop AVN?
It depends on whether you do a non-vascularized graft or a vascularized graft. And in my experience, I would say 85 to 90% will heal with non-vascularized graft, but 90 to 95 heal with vascularized graft. Can we hear from Anirban?
Anirban?
Yeah, the proximal pole, if it is ideally fixed, then it should unite. Now, the percentage of AVN is difficult to predict. I often don't have any numbers to give, but the important thing to remember is that the proximal pole, because it's a small fragment, the ideal fixation has to be really ideal.
Yeah.
Otherwise, the margin of error is very small.
So this is an interesting question. Again, a kind of continuation of this from Dr. Ashok Ajni Ahmedabad, who is asking specifically to Dr. Parag, but I will throw his question a little modified way. What he's asking is, Dr. Parag, does early fixation as we believe in neck fractures in the hip. I will modify it because now we believe in hip that the quality of reduction is more important than the timing.
The timing.
So it did not be first 6 hours or first 8 hours, but it has to be absolutely precise and anatomical and don't accept anything at all. Does that also hold true timing wise and quality of reduction wise in scaphoid? And let everyone answer on this pertinent question. Parag.
So yeah, I answered this gentleman on the chat as well, that it's not a middle of the night emergency. You've got to go in with your best, with your A team. When you have a complex four-part fracture dislocation, you must have a perfect setup, all the implants, and a good team. So I would do it as soon as possible. Try to get the best anatomy restoration as possible, and do it. I mean, the case that I showed, I operated after 7 days. So, and it's not unusual for people to have a certain delay before they end up at your clinic. So no, and there is not much written in the literature about timing of surgery in proximal humeral fracture dislocations. So no, I do not believe that it has to be rushed in. But yes, you get to it as soon as possible with your best team and all your stuff with you.
Dipti?
Yeah, I think with any intra-articular injuries, if you are early, then it's better. But it is not an emergency.
Ram, any different?
Agree with that, except that one point is that you have to remember there is also a possibility of axillary artery or axillary vein compression, undue swelling, neurovascular compromise is there. Then you have to.
Then it's an emergency.
And that's an emergency. Don't assume that the four-part fracture dislocation would be always like fracture dislocation only. Neurovascular element, especially vascular, has to be attended.
Sure. I think there are many questions still remaining, but I'm sure Juventus and Science Integra will put forth this to us at a later date, and maybe Vidisha, you can take this forward at a later date and we can answer all of them. May I take this opportunity to thank all of you on behalf of Trauma Society of India and Juventus and Science Integra to come and spare your valuable time. Ram, Parag,
Thank you.
Anirban, Dipti, thank you very much. Vidisha, terrific job, well done as a moderator, and I really appreciate that. With this, I call it a day. Stay safe, all of you. Corona
Thank
times,
you.
difficult times.
Thank you.
But
Thank
hopefully
you.
we'll meet very soon.
Thank you very much.
I will reconnect with all of you in next 2-3 days on a different platform. This time it's not TraumaCon Mumbai, it's TraumaCon World happening. So please block your dates. All of you are there, so please know it. 15th and 16th of August continues, but it's a global meeting this time. So we are working day and night, talking day and night, literally, because there are some American speakers, there are some Australian speakers. We have to cover all time zones. So it's crazy. Parag, stay around, stay connected. Thank you very much.
Thank you. Thank you very
Take
much.
care, all of you.
Thank you.
Bye now. Allah, thank you very much.
Thank you, sir. Thank you.
You want to say something, Allah?
No, I just wanted to thank everybody for the precious time each one of you have spent with us. And I think so it was time well spent for everybody. It was a scientific piece from whatever I could get. Right. Thank you so much. Thank you so much.
Thank you. Thank you. Take care. Bye-bye.
Bye-bye.
Thank you, doctors. Thank you, Vidisha madam. Thank you, Shushrat sir. Thank you so much.